Good afternoon. Welcome to the fifth webinar on COVID-19, sponsored by the European Society of Endocrinology, that will be dealing with the topic of hyponatremia and diabetes insipidus. I will be the chair of today's session. I am Mónica Marazuela. I'm current secretary of the European Society of Endocrinology. I am really proud to be here surrounded by all these very well-known experts in the matter. I am a clinical endocrinologist with special focus in pituitary and thyroid disorders. I work in Madrid, and as you may know, Madrid has been a very important focus in the COVID-19 pandemic, and it has helped us to gain experience in the subject. The alterations in water metabolism are an important complication of these very ill patients, and its diagnosis and management should be done by expert hands of endocrinologists. To comment in this subject, we are very lucky to have an incredible group of specialists in sodium and water metabolism that will bring very interesting ideas to the discussion. I would like to introduce first to our speaker, Miriam Crane. She's a professor of endocrinology at the University of Basel, and her main area of research has been on vasopressin-dependent disorders, mostly in diabetes insipidus and hyponatremia. She has just published a superb review in the subject of sodium metabolism and diabetes insipidus during COVID at the European Journal of Endocrinology. We also have a very talented speaker on the matter, Dr. Chris Thompson, that works as professor on the RSCI Medical School at Dublin. He's a very well-known world specialist in hyponatremia and water metabolism. And our third speaker is Dr. Alessandro Peri. He's professor of endocrinology and chief of the sodium alterations unit at the Mario Serio University of Florence. He's also very involved in the sodium and water metabolism, and he has just published a very interesting article at the Journal of Endocrinological Investigation about water metabolism and COVID. So welcome to our great speakers. I'm sure that we are going to have a very, very interesting seminar. And to all of you, please remember to write your questions in the question and answer section, and I will try my best to ask them at the end of the talk. So welcome to our speakers. You can start now.
So thank you very much, Monica, for this introduction and for chairing this session. Welcome to everybody around the world, mainly from Europe, but also from other countries. And it's my great pleasure to present here this ESE talk and webinar about endocrine conditions in the COVID-19 area, specifically today, diabetes insipidus and hyponatremia. And it's also my great pleasure to welcome the two panelists, Chris Thompson and Alessandro Peri, two great specialists in fluid disorders. And they will be present during the discussion after the talk. But first, Alessandro will also show some slides for his study in this topic, and Chris has prepared a case report about the management of a patient with hyponatremic dehydration. So importantly, the work that I will show you is the result of all these authors, Ewald Horn, Mark Sherlock, Chris Thompson, John Wass. So I will present on behalf of all of them. And this paper has been published in the European Journal of Endocrinology some weeks ago. So if you want, please feel free to see some more details of what I will show you in the following slides. Now, the aim of this webinar is to discuss the management of fluid disorders like diabetes insipidus and hyponatremia in times of COVID-19. So in principle, these patients should not be more prone or vulnerable to be infected with COVID-19. But first of all, the management of these patients in the outpatient setting in times where regular phlebotomy or physical contact is not possible, may be somewhat complex. And second, if these patients are infected with COVID-19, they are at significant increased risk to develop dysnatremia. So the following situations will therefore be discussed. First, the management of diabetes insipidus in the outpatient setting in times of COVID-19, where, as mentioned, the regular phlebotomy may not be possible. And the second, maybe the more important topic, the management of diabetes insipidus hospitalized with acute COVID-19. And then concerning hyponatremia, the management of hyponatremia, again, first in the outpatient setting, and then hyponatremia in patients hospitalized with acute COVID-19. And here we would like to discuss two questions. First of all, what's the prevalence? How often do we see hyponatremia in these patients, also compared to hyponatremia and other etiologies of pneumonia? And second, what is the management of hyponatremia in these patients? So the first situation is the management of diabetes insipidus in the outpatient setting in times of COVID-19. The principles of management outlined in guidelines still form the basis of treatment, and we won't go into detail here. If there are questions, we can discuss after the talk. We will focus on central diabetes insipidus, and here the treatment, as you know, is exogenous desmopressin. Desmopressin can be applied via different routes: the parenteral route with IV, subcutaneous or intramuscular injection, intranasal, oral, or sublingual application. So the parenteral route is not for the routine use, it's for the patients acutely hospitalized. I come back to that in a minute. And in routine use, we usually start with an oral or intranasal dose at bedtime, so that patients are not symptomatic with polyuria, polydipsia during the night. And if they are still having symptoms during the day, we then add a dose in the morning. So usually we start with an oral dose of 50 to 100 micrograms, or 1 hub, which is 10 micrograms of the nasal spray or the oral tablets. However, the main complication of desmopressin is hyponatremia, dilutional hyponatremia. And this side effect is actually not known to many patients and also not known to many physicians. But previous series have shown that there is a 27% incidence of mild hyponatremia and 15% of more severe hyponatremia after long-term follow-up. And in fact, post-marketing surveillance has shown that there is less risk for hyponatremia with the oral formulation compared with the intranasal formulation. Probably because there is a less consistent absorption when using the intranasal formulation. So it may be prudent rather to start with the oral instead of the nasal formulation. So what is important, especially in times of COVID-19, where the regular phlebotomy may not be possible? So because of this risk of hyponatremia, it's especially important to inform our patients about this existing risk for hyponatremia, especially if they are drinking too much. The patients should also be aware of the early symptoms of hyponatremia, like bloating or headache or nausea. They should be advised to drink only to thirst and to regularly control their body weight and to stay at a eunatremic weight. We also advise our patients to delay desmopressin doses once, or in those patients who have already experienced hyponatremia, even twice weekly, to allow for free water diuresis. So this is to avoid dilutional hyponatremia and the overdose of desmopressin. So what about the management of diabetes insipidus hospitalized with acute COVID-19? And it's really important to bear in mind that these patients have a significant increased risk for development of dysnatremia, and I will show you that in the following couple of slides. This is not a COVID-19 study, but it's an earlier study from 2015 from Behan and Sherlock, but it illustrates that patients with central DI admitted to the hospital are at increased risk for dysnatremia. You see here in the middle column the neurosurgical admissions, where 77% developed an abnormal sodium level, 27% sodium below 130 millimole per liter, and 23% above 150 millimole per liter. And if you look at the non-neurosurgical admissions, then 60% had an abnormal sodium, 74% hyponatremia, and almost 20% hypernatremia. So these are quite high numbers. Another report showed that in patients hospitalized with central diabetes insipidus, desmopressin actually had been missed or delayed in almost 90% of all admissions, and 35% of the patients consequently then developed dysnatremia. So even if this is not COVID-19, it shows that patients with diabetes insipidus who develop respiratory complications of COVID-19 are at increased risk of dysnatremia. And therefore, based on these studies and report, the Society of Endocrinology has developed guidelines for the inpatient management of central diabetes insipidus 2 years ago. And these guidelines actually are also valid for the management of central diabetes insipidus in COVID-19 patients. And in the following slides, I would like to guide you through this paper. So first of all, there are certain patient groups who are at particular risk for rapid deterioration of central DI. And these are certainly patients with acute or chronic confusion, reduced consciousness level, unable to self-administer desmopressin. Patients with adipsia or osmoreceptor dysfunction is a special challenge, and I will come back to that later, or patients also who have multiple transfers within an institution. And many of these criteria may apply to patients with COVID-19. So the cornerstones of the guidelines are first the assessment of fluid status and sodium levels, the monitoring of sodium and urine output, and then mainly the choice of fluid replacement and the desmopressin treatment. And I will go into more detail for these two steps of the guidelines. But as a first general remark, all patients with diabetes insipidus admitted to the hospital with COVID-19 must be managed in consultation with the endocrinology advice. And it's especially important to have a careful prescribing alert system for all patients treated with desmopressin to reduce that desmopressin is missed or delayed and that prescribing errors occur. What about desmopressin treatment? Now, for those patients with severe COVID-19 illness, we recommend the parenteral therapy. And we here would recommend the IV route because it obviates the concerns about absorption and has a similar duration of action as the other parenteral therapies. And the prompt decrease in urine output should be seen. So we recommend then to monitor urine osmolality and urine volume and to measure plasma sodium in frequent intervals, of course, more often if there is dysnatremia and less often if there is a normonatremia. In those patients with more mild COVID disease who are able to drink, it may be advisable to prescribe the oral instead of the nasal desmopressin because of concerns, because of the absorption in nasal congestion. And also because, as I showed you, there might be less hyponatremia in the oral, with the oral dose and compared to the nasal dose. Patient empowerment is also important here so that patients know that they are dependent on the desmopressin dose. Then fluid therapy in case of hypernatremic dehydration, and we will hear more about that in the case report of Chris in the end. So in patients with hypovolemic shock, we recommend treatment with the IV 0.9% sodium chloride, even if there is hypernatremia. And in all other cases, in the absence of hypovolemic shock, we'd recommend to treat the dehydration with hypotonic fluids, either enterally if possible, or intravenously with 5% dextrose. However, and this is important, ARDS, often with pulmonary edema, is a quite common complication in COVID-19. And therefore, we endocrinologists might have to accept a mild hypernatremia, because if we give too much of fluids, then the risk of pulmonary edema is increasing. So it's important that the fluid management is done in collaboration of ICU colleagues and the endocrinologists. This is just a short overview about the sodium content of common infusates. You see the 5% dextrose being the most hypotonic fluid and has no sodium. The 0.45% sodium chloride contains 77 millimoles sodium per liter, and Ringer has 130 millimoles sodium per liter, and the 0.9% sodium chloride has 154 millimoles sodium per liter. Now, also important as a further treatment, these patients should have a routine prescription of prophylactic subcutaneous low molecular weight heparin, because hyponatremic dehydration is associated with a hypercoagulable state. And this is especially important since pulmonary embolism has emerged as a risk factor for mortality in COVID patients. And therefore, these patients certainly should have the low dose heparin treatment. Patients with adipsic DI or osmoreceptor dysfunction are a special challenge because these patients do not have thirst perception. So besides, of course, education of these patients and their families, and besides desmopressin treatment, they need a prescribed amount of fluid intake. Usually this is 500 to 1000 mL above the urine output to assess for insensible losses. And it's also important that they regularly monitor their body weight on a daily basis and should stay at their unatremic weight. So, for example, if they have half a kilogram below the unatremic weight, they should be advised to drink half a liter of hypotonic fluids. So if I summarize the treatment of DI in times of COVID-19, then the main risk factor in the outpatient setting is the dilutional hyponatremia, and the protective measure is to delay desmopressin dose once or twice weekly, to advise these patients to regularly control body weight and to stay at a unatremic weight and to drink only to thirst. And if these patients are admitted to the hospital, they have a high risk for dysnatremia due to, on one side, the missed or delayed desmopressin dose, but also because they might not be able to have enough fluid intake because they have increased insensible losses if they have fever, and maybe they need diuretic therapy for pulmonary edema. So it's important, again, as protective measure, to have the endocrine consultation for every patient with DI to reduce the prescribing errors and advise with fluid management. Patient empowerment is important, and of course an appropriate stress dosing of corticosteroids in those patients who have an additional ACTH deficiency. If these patients are in the intensive care setting, the routine care is as per published guidelines with a careful attention to desmopressin dose and fluids. And in case of hyponatremic dehydration, we give hypotonic IV fluids with the agreed target to reverse hyponatremia being urine losses and plus insensible losses. However, we have to carefully monitor for ARDS and pulmonary edema, maybe to accept mild hyponatremia, and these patients need a prophylactic anticoagulation. So with that, I come to the second topic, which is hyponatremia. And again, first, what's the management in the outpatient setting in times of COVID-19? And here we focus on those patients after pituitary surgery. Now, most elective pituitary surgeries will probably be cancelled in times of COVID-19, but neurosurgical interventions due to subarachnoidal hemorrhage or traumatic brain injury may still continue to induce SIDH and hyponatremia. And the risk of hyponatremia due to SIDH is typically seen after the discharge from the hospital. And therefore, again, in times where the routine phlebotomy may not be possible, prevention and awareness, which are of course always important, but are specifically important here. So what should we do? We should draw the attention of patients and primary care physicians to the possible occurrence of hyponatremia and also to the early symptoms of hyponatremia. The patients should again be advised to limit their fluid intake in the 2 weeks following surgery and to drink only to thirst. Again, also these patients should measure their body weight daily and stay at the unatremic weight. And they should contact their primary care physician or their endocrinologist in case of early symptoms of hyponatremia, which they should know, like weight gain, bloating, unusual headache, nausea, or fatigue. And in all other patients with chronic SIDH treated with fluid restriction or with urea or with Vaptans, they should be advised to continue their treatment and again to know about the early symptoms of hyponatremia and to contact their primary care physician or endocrinologist if they have these early symptoms as shown before. So if I summarize this brief part, the risk here is the new diagnosis of SIDH after neurosurgical interventions, and patients should be advised to limit fluid intake for the 2 first weeks following surgery, measure their body weight daily, and aim to stay at the eunatremic weight, drink only to thirst, and know about the early symptoms of hyponatremia. So what about hyponatremia in patients hospitalized with acute COVID-19? And as mentioned in the beginning of my talk, I would like first to focus on the prevalence of hyponatremia. So how often do we actually see hyponatremia in these patients? And then on the management of hyponatremia. So hyponatremia is generally common in pneumonia, especially in atypical pneumonia, where we see it in up to 50% in Legionella pneumonia. The most often seen etiology is SIDH, which we see in 60% of hyponatremia in pneumonia, and 40% have hypovolemic hyponatremia. In general, hyponatremia in pneumonia is associated with a worse outcome like mortality or ICU admission, and it's not known whether this is a pure association or causality. Causality would actually mean that if we correct sodium levels, then we would improve outcome, and currently we do not have these data. In SARS, we know that 60%, so quite a high percentage, had mostly mild hyponatremia. But what about COVID-19? And of course, there are not much data available so far, but I will show you what data we have until now. So first of all, this is a small series from the United States looking at clinical features, laboratory characteristics and outcomes in patients hospitalized with COVID-19. You see it's small, it's 43 patients hospitalized with COVID-19, and here 50%, so again, quite a high percentage had hyponatremia. But there was no association of hyponatremia with outcome, although this is difficult to assess in such a small series of patients. Then there is this report describing 3 cases of SIDH in patients hospitalized with COVID-19. And the authors here claim that SIDH in COVID-19 is quite common and could be a clue in times of pandemic. They also suggest that it could be induced by the high inflammatory cytokines like IL-6 or IL-1. And I will come back to that when showing Alessandro's report. However, other reports, and this is a large Chinese series published in the New England Journal of Medicine, and this report did not specifically look at sodium levels, but they report sodium levels. So you see here the median and interquartile ranges are 138, and here the interquartile range. So this is all in the normal range. The ranges, which are not shown here, they might show some patients, of course, with hyponatremia, but still the majority of patients is normonatremic here. And the same is true for this, also a Chinese series, where you see these are patients with normal imaging findings, and these are patients with abnormal imaging findings. So the normal imaging finding patients had 139 millimole per liter, and slightly higher than those patients with pneumonia having a sodium of 138 millimole per liter. But still, the majority here is in the normal range. And then this is the report from Alessandro, where you will see and hear more details afterwards. He and his group looked at 52 patients with a laboratory confirmed COVID-19, and they showed, interestingly, an inverse correlation of sodium and IL-6. This is shown in this graph, where you see the lower the sodium level, the higher were IL-6, or the other way around, the higher sodium, the lower IL-6 levels. This group also showed an increase of sodium after treatment with an IL-6 inhibitor, tocilizumab, which is shown in this graph. In white is the control, and the other is the tocilizumab group, where you see the initial evaluation, and here the levels after 48 hours of treatment. So in tocilizumab, the sodium level increased significantly within these 48 hours after tocilizumab treatment, whereas there was no significant increase in controls. In this paper, hyponatremia was associated with more severe outcome like death or ICU admission. And the conclusion here is that first, sodium could be an early marker for more severe, for advanced disease. And second, it could be an additional parameter to be included in the criteria for a tocilizumab treatment, which of course has to be verified in a larger cohort, but it's a very interesting approach. As mentioned, there are not much data so far, and this is not data, that's just the first experience in Dublin, Rotterdam, and Basel, so from Chris Thompson, Eva Thorn, and myself. And we have the feeling that we see more hypernatremia than hyponatremia. And possible reasons is the high frequency of volume depletion in COVID-19 due to an increase in insensible fluid losses, use of diuretic therapy to treat pulmonary edema. And these factors tend to produce hypernatremia rather than hyponatremia. But the prevalence of hypo or hypernatremia may be heavily dependent on the different local protocols for managing fluid balance. And Alessandro will say some more words for that. So what about the management of hyponatremia in COVID-19 patients in the intensive care setting? The routine care, again, is as per published guidelines. In case of hypovolemic hyponatremia, because hypovolemic hyponatremia is associated with a higher mortality than SIDH. So if there is doubt or if there is hypovolemic hyponatremia, we recommend to give IV 0.9% sodium chloride solution with a rate individualized to the patient and agreed with intensivists. But again, with a careful monitoring for ARDS and pulmonary edema for the reasons I showed before. And similar caution is required for acute severe hyponatremia with cerebral irritation. Here the aim is to elevate sodium by a maximum of 8 to 12 millimole per liter per 24 hours as per guidelines, even lower if there is a high risk for pontine myelinolysis. And usually the guidelines recommend to give the bolus IV infusion of 3% saline, but due to the risk of the sudden volume overload here, it might be more prudent to give the continuous IV infusion. But there is not enough evidence here, and of course every center should use the protocol with what they have most experience with. And again, of course, sodium has to be monitored regularly. So with that, I'm at the end of my talk, and I hope we have shown you some insights into the management of fluid disorders during the COVID-19 times. And I now pass over to Alessandro first for his slides about the study I briefly introduced, and then to Chris Thompson for the case report in hypernatremia. Thank you for your attention. Alessandro, it's yours.
Yeah, thank you, Miriam. Good afternoon to everybody, and thank you for attending this meeting. So as Miriam already showed you, that we recently published a brief report with some preliminary data about hyponatremia and interleukin-6 and COVID infection. Let me thank these guys who really helped me a lot in preparing this data, in particular Dr. Andrea Berni and Dr. Danilo Malandrino, who are doctors who work in a COVID unit in the last couple of months, so every day. Okay, so Miriam already mentioned some of the data we published. I would like just to draw your attention on this fact. The second sentence, hyponatremia associated with more severe outcome, meaning non-invasive ventilation, ICU admission, or even death. And we found in our, of course, small series of patients so far that in 53% of patients who had hyponatremia at admission, there was the need of non-invasive ventilation or ICU admission, compared to only 7% of patients with normonatremia. So this is a big difference. And then Miriam already mentioned that patients who were treated with tocilizumab had an increase in serum sodium, and this was these are the data. So at the beginning, before treatment, patient had a mean concentration of sodium of 132 milli equivalent per liter, and after 48 hours of treatment, the sodium raised to 140, almost 140, so completely normalized. So Miriam already showed you the hypothesis we made. We thought that sodium could be an early marker for advanced disease in COVID patients, and the advantage is that it can be readily available, especially with the point of care testing for arterial sodium. Now I would like to show you just a few other data from, so Miriam, if you can go ahead, please. Okay, so we hypothesized that serum sodium could be also a sort of surrogate marker of respiratory function in COVID-19 patients. And this turned out to be true. In fact, we divided patients into two groups. Those with high IL-6 levels above the upper limit of normality for our lab, which is 10 picogram per ml, and those with normal IL-6 levels. So you see that not only serum sodium was lower in patients with higher IL-6 levels, as already Miriam mentioned, but we had observed also that patients with high IL-6 levels had a lower P to Phi ratio, which is a recognized and validated index of the respiratory function, which takes into account the arterial oxygen pressure and the fractional inspired oxygen. So this is a validated marker of respiratory function. And interestingly, if you look at the bottom part of the figure, you see that there is a direct correlation between sodium and P-Phi ratio. So meaning that from a clinical point of view, it looks like that low sodium corresponds to a more pathological respiratory function. And so this is, these are some other data that I wanted to share with you from our recent publication. We are, of course, increasing the number of patients. In Florence, we had more than 500 patients with COVID just in one university hospital. And so, of course, we are increasing the numbers, and the data looks to be basically the same. And so we are going ahead with this kind of research. And now I think that, yeah, Chris has to show some slides. So
good evening, everybody. You're very welcome to this part of the presentation. And following on from Miriam's discussion about the difficulties in fluid management with hyponatremic patients, I thought I would present a typical patient who was admitted under us in Beaumont Hospital in Ireland. This is a 62-year-old man who presented to ED with a fairly typical history of somebody in respiratory difficulties from COVID-19 infection. He'd had at least a 5-day history of high fever, really profuse sweating from the unremitting high temperature, and a cough and dyspnea. It seemed as if he'd probably contracted this from his wife, who's a little bit younger, who had been a care home worker, that the care home had been known to be a place where there had been a lot of COVID-19, and she'd had a much less serious illness the previous week, where she'd had mild flu-like symptoms, but certainly not the serious symptoms that this man had. Now, this man had a lot of comorbidities that would predispose him to a worse outcome from COVID-19. He had hypertension, he'd had a coronary artery stent, and he had type 2 diabetes with established microalbuminuria, indicating that he likely had underlying endothelial dysfunction due to diabetes, as well as vascular disease with his hypertension and the coronary artery disease. Move on there. So when he came in, having been treated through the COVID pathway in the hospital, he was found to have tachycardia, he had significant hypotension, and he was tachypneic. His chest X-ray showed typical diffuse opacities bilaterally, and he was in respiratory difficulty with type 1 respiratory failure, but a CO2 which was rising during the course of his admission. because he'd really had a difficulty prior to coming in with his high fever, his sweating, and because he'd been tachypneic with an increased respiratory rate, he'd also been unable to maintain his normal fluid balance. He hadn't been able to drink very well, and he was on a small dose of furosemide for his coronary artery disease. But when he came in, he was significantly hyponatremic with a plasma sodium of 152, and he had evidence of an acute kidney injury, which had not been noted previously, with an elevated blood urea and an elevated creatinine. And this was typical, really, of many of the patients that we dealt with who'd had difficult experiences with COVID, in contrast to our own database of patients with viral pneumonia due to other causes that we compiled during the SARS epidemic. We didn't see as much hyponatremia as we'd expect with other forms, either bacterial pneumonia or viral pneumonia. But what we did see was quite a significant incidence of hyponatremia associated with COVID. Next slide, please, Miriam. So our clinical priorities here were really support of the patient with maintenance of the PO2, the reversal of hypotension and hypovolemia, reverse and prevent worsening of his acute kidney injury, and the prevention of thrombotic episodes, which Miriam has commented upon, have been a very severe complication of a lot of people who have bad COVID-19 disease. The reversal of hyponatremia, as an endocrinologist, and particularly as an endocrinologist who's interested in salt and water balance, this would normally be top of my priorities, but in this clinical context where we were having to protect the integrity of the kidneys, we're having to protect tissue perfusion, we're trying to oxygenate the lungs, the reversal of hyponatremia, although a priority, was much lower down the list of priorities than maintaining the oxygen flow, giving IV fluids to expand the plasma volume, reperfuse the kidneys, reverse the acute kidney injury, and the prevention of thrombotic episodes. Like Miriam, we would, in this circumstance, recommend for low molecular weight heparin, though of course in the COVID literature there is some suggestion that the difficulty with clotting or hypercoagulability may be upstream of the parts of the clotting cascade which could be helped by heparin, but certainly we would be looking to try and prevent any possible preventable thromboembolic episodes. So hypotonic fluids is there on our list of clinical priorities, but not necessarily up at the top of what we want to do. Next slide. So, and again, next slide. So our clinical concerns that we found, and this would be something perhaps that we could discuss when the questions come up, and that I'd be interested in the views of Alessandro and Miriam, is that if we pursued a course of aggressive fluid replacement with this patient who's over 60, who has got a number of conditions that would predispose them to endothelial dysfunction, we would risk increasing the likelihood of him getting ARDS with pulmonary edema. And of course, what we found in many of the people who perished from COVID-19, this was the pre-morbid condition which led on to death. Whereas on the other hand, Miriam, the more gentle rehydration would be associated with worsening renal function, a prolongation of the hyperthrombotic state, and the effects possibly of hyponatremia on the brain. And of course, we know that in other conditions, it hasn't been shown necessarily in COVID-19, hyponatremia is a very important independent predictor of worse outcome. So this is a clinical concern where the two forms of treatment both have downsides. I think we resolved a middle ground between these two clinical concerns, whereby we treated more or less every patient on individual merits with very careful monitoring of pulmonary wedge pressures, careful screening for pulmonary edema, but giving enough fluid to maintain renal perfusion and hypothrombotic states. So that's really opening up for discussion what the best options are for the endocrinologist who's involved in consultation for hyponatremia. And I would be interested in the views of my co-panelists and any of the people who've elected to participate today.
So we are open for discussion. I will be asking the questions to the speakers. The first question, it will be for Dr. Thompson. What are the recommended limits for correction of hyponatremia? And what will be the risk factors for development of pontine myelolysis? And how should we handle it? So big questions for big doctor.
Okay. I think that my own experience is that we haven't seen anybody who has developed acute symptomatic hyponatremia with COVID-19 infection. There has been a number of episodes of milder hyponatremia, but should it occur, I think that the parameters that would be considered would be the parameters given in the international guidelines. I wonder if I can go back to the reserve slides that I had there, Monica. So these would be the sort of recommended targets for the management of severe hyponatremia, irrespective of the causation of the hyponatremia, and that in a standard patient, you would looking for a target in plasma sodium of no more than 8 millimoles per liter over 24 hours, and a maximum rise of 12 millimoles per liter in 24 hours. Many of the COVID patients will be have other comorbidities, and in patients who are also have alcoholic liver disease or malnourished or have hypokalemia, there would be a lower target rise in the first 24 hours of 6 millimoles per liter and a maximum of 8. I don't think there'd be any reason to change these targets in someone with COVID-19 infection. So I would say that these would be exactly the same. In practice, I don't think there have been many patients who have had the sort of acute severe hyponatremia with neurological consequences that require the sort of intervention that I've documented here with bolus or continuous infusion of hypertonic saline. I don't know if that answers the question, Monica.
Yeah, I think the question was very well handled. Thank you. There's another question for Miriam. It's how is SIADH diagnosed in the hospitalized patient? Do you measure vasopressin or copeptin?
Yeah, thank you, Monica. So the diagnosis of SIADH is actually according to guidelines as well. So there should be hypoosmolar hyponatremia with a high urinary of 100 and a high urinary sodium level above 30. And there should also be clinical euvolemia, although we know that it is sometimes very difficult to assess. And very importantly also, it's a diagnosis of exclusion. So we really have to exclude adrenal insufficiency because if cortisol is low, that can give a feedback to the hypothalamus pituitary. So ADH is increased, and we have a similar laboratory constellation like in SIADH. So if cortisol is low, these patients need hydrocortisone, and the treatment therefore is very different from fluid restriction in SIADH. Vasopressin or the copeptin, unfortunately, is not very useful here because it is increased in almost all different etiologies of hyponatremia, except in primary polydipsia, where it is adequately suppressed. That's the only where it makes sense to measure it. If it's very low, that points to primary polydipsia. But in all other etiologies, in hypovolemic, in hypervolemic hyponatremia and in SIDH is more or less increased and with a large overlap. So it's not really, it does not really make sense to measure it for diagnosis.
Another question is what about the treatment of SIADH in the acutely hospitalized patient? What is your experience with Baptans and urea? To Dr. Alessandro Peri. Should I repeat or did you?
Okay. It's okay. All right. It's a complex question because if you think about acutely hospitalized patient, meaning that we have in acute and severe hyponatremia, of course, the treatment, the gold standard for treatment is hypertonic saline solution, and as already Chris mentioned. So I wouldn't, of course, I wouldn't suggest, not only me, all the European guidelines, the American and Irish, I have to say, recommendation do not suggest, of course, the use of urea or Vaptans in severely acute hyponatremia. Vaptans can be used for moderate or mild hyponatremia, secondary to SIADH, yes. We have quite a good experience because we have been using these drugs. Actually, the only available drug in Europe is tolvaptan. And we know that it is very effective in correcting hyponatremia. Actually, it's much more effective than we thought at the beginning. So that the traditional doses had to be lowered to from 15 milligram per day to 7.5 milligram per day, or sometimes also to 7.5 milligram every other day. What we know is that usually the lower the sodium is, the more effective the drug is. So that's another reason why I think it cannot be suggested in acutely severe hyponatremia, because then there would be probably the risk if you use, especially if you use traditional doses, to have an overly rapid increase of serum sodium with Vaptans. Although if these drugs are properly used, I would say that you don't have this kind of risk because actually we have experience from publications that if an overly rapid increase occurred, it was because sometimes tolvaptan had been used together with other active treatments for hyponatremia, and that shouldn't be. With regard to urea, I don't have personal experience with urea. I have to say I've never used urea. I know that it is suggested by the European guidelines and American recommendations, but of course it doesn't have a good compliance because of its bitter taste. And yeah, it is effective because it increases free water excretion and reduces sodium urinary excretion. But I really don't think that, at least in Italy, I don't know in other countries, we don't really use urea. Also because I have to say that in the 90s there had been papers reporting cases of overly rapid increase of serum sodium by using urea. So it's not completely void of any kind of risk. But maybe my other colleagues have used or have been using urea. I don't know.
Maybe I can add, Alessandro. I mean, we had in Switzerland, we didn't have Vaptans for a long time, although it was available in Europe, in whole Europe, but in Switzerland, we only got it, I think, end of last year. So we do not have much experience with Vaptans, so we were using urea, and in my experience, quite successfully. Of course, it has a bit an odd taste. We usually give it together with orange juice, but it seems to work. But we don't have the large data, of course. Maybe I can also add, because I've seen there is one question of the audit concerning SGLT2 inhibitors, which of course is one of my favorite topics, because we did one study. If you block SGLT2 receptors, then glucose is not reabsorbed, but it's excreted with the urine, and you have an osmotic diuresis. And this is also working. So sodium increases significantly to a significantly higher level than placebo. It's only 80 patients, and we have to show that in a larger cohort, but that may be also an alternative to Vaptans in the future.
Or shall we go for the next question? What about the management of nephrogenic diabetes insipidus? Who would like to answer this one? Because they didn't ask for a special speaker. Chris, Miriam, whoever. Chris, would you like to help with this one?
Yes, the management of nephrogenic diabetes insipidus is much more difficult than for central diabetes insipidus. There isn't a specific antidote like there is with desmopressin. I've not seen anybody come in with COVID-19 with nephrogenic DI, though we are, I think probably if we saw someone coming in with nephrogenic DI, the most likely scenario would be somebody who's on lithium therapy, and we know that 15% of people on chronic lithium therapy develop nephrogenic DI, which may or may not be reversible on withdrawal of the drug. One of the difficulties with managing patients on lithium is that, in contrast to patients with central diabetes insipidus, they don't seem to have the same thirst mechanism as patients with central diabetes insipidus. And I would defend that statement by saying that Miriam referred to the paper showing that if you look at outpatients with central diabetes insipidus, there's virtually no incidence of serious hyponatremia because the thirst mechanism protects against this. But unusually, with patients with lithium-induced nephrogenic DI, even who are ambulant and who are otherwise well, there is quite a significant incidence of hyponatremia, and this gets worse when patients are admitted to hospital. So although I've not seen anybody come in the COVID-19 era with nephrogenic DI, I think that the potential in that circumstance, if somebody comes in with lithium-induced nephrogenic DI, might be for even worse hyponatremia than we're seeing with some of the patients coming in. And there might be more of a need for reversal of this with hypotonic fluids.
Okay. We're going to the end, but we still have time for one more question. The diagnosis of hyponatremia in patients in the ICU. How can you differentiate between diabetes insipidus and other etiologies of hyponatremia? Whoever who would like to answer this question, do you continue, Chris, or Alessandra, Miriam, whoever?
Well, I think we'd all be expert on this, but Miriam has written very extensively on the diagnosis, differential diagnosis of polyuric states and diabetes insipidus. So I'd be happy to let Miriam take this over. I'd be interested to hear what she says.
Well, I'll give it back to you afterwards, but maybe just a short comment. It's of course difficult to make a correct differential diagnosis, and it needs a proper clinical assessment and a history of the patient. The most common etiologies is either dehydration, as we have seen in the case report of Chris, or it can be iatrogenic, and in very rare cases, of course, it can be nephrogenic or central diabetes insipidus in these patients. As mentioned, this is a rare situation. And copeptin or vasopressin measurement is only, makes sense only for those patients where we suspect central DI, and there it is low. In all other cases, it is actually very high, especially in dehydration, of course. Maybe you want to add, Chris, something.
If we're looking at somebody who is being that we consider the possibility of diabetes insipidus as opposed to just hyponatremic dehydration. Probably the most important thing is to look at the urine output, because if you've got someone who's just coming on with dehydration, they're going to have a low urine output with very highly concentrated urine. And then if you've got somebody who is obviously polyuric with dilute urine, the differential diagnosis is the one that Miriam has published so elegantly on in recent years. You've got a different circumstance then. It's a possibility of diabetes insipidus, nephrogenic diabetes insipidus, etc. In that circumstance, because you can't go through the normal process of water loading, sort of water deprivation or hypotonic saline, someone who's acutely unwell, I still think the old diagnostic criteria of Sekel and Dunga of polyuria with hyponatremia and dilute urine are probably the ones that we use to acutely diagnose central DI. And you have to use your clinical acumen often to differentiate between nephrogenic and central DI in a situation where you have to make a quick diagnosis. But in adults, we would very rarely see nephrogenic DI as a new diagnosis unless the patient was on lithium.
So I think that unfortunately this session has come to an end.
Just can add a little thing.
Okay, yeah, of course. We do have like a couple of seconds more or less. Yeah, go ahead.
No, just about diabetes insipidus, because I saw a question about megaureter in diabetes insipidus. And I have to say that I've seen cases like that, but they were all cases of congenital nephrogenic diabetes insipidus, where you have huge loads of water, of losing water with urine and drinking a lot. And so these guys, unfortunately, can go into having, can have really problems and megaureter and urinary retention. But yeah. I have only seen in these kind of patients. Congenital nephrogenic diabetes insipidus.
Okay, very good comment. So unfortunately, our session has come to an end. I would like to thank the speakers. It has been a great pleasure to chair this session with all these great speakers and specialists in the matter. Thank you so much for being with the ESE and for this great seminar. We are looking forward also for the next seminar on COVID-19 and thyroid disorders that will take place next week. And you're also welcome to attend. And so I also would like to thank all the attendees for being here. And I hope that you would have liked this incredible session. So thank you so much. Bye.